when you've got somebody with a metastatic lung cancer diagnosis, I think now certainly it's standard of care to be looking at mutational and next generation sequencing of their tumor. And ideally we're trying to take the biopsies from the, take the biopsy from the tumor itself and do this type of analysis. And initially that was looking at some of the mutations like EGFR, which was probably the most common one that we had medicines to target, and then later became EML, ALK, because we had medicines to target, and ROS1. Again, ROS1's pretty rare, about 1% of patients with lung cancer, but we had medicines that would target. And now you're seeing more and more of these mutations where they're not extremely common mutations, but if we find them, we may have actual medicines to offer those patients, and starting to get into that, I guess, that dream of personalized medicine for each of these patients, where they, even though they might all have a diagnosis of metastatic lung cancer, it might be different paths that we're having to take to treat them all. And so, so I think where these kind of next generation panels, where they're much larger panels that look at these different mutations, are becoming more and more important. And to me, I think that's the way probably it should be going, where physicians are not just doing these one-off mutational testings, but these big panel mutation testing, so we can look at things like the MET exon 14 skipping mutation, and look at HER2, and look at ALK as well. And so you're using these kind of bigger panels to be able to analyze all of that. And hopefully with those bigger panels, you can accomplish that without having to use so much tissue, essentially.